Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Mona Potter. She's a physician executive. Today's Kevin MD article is When Anxiety Runs the Show, How Medication Can Help Kids Thrive. Mona, welcome to the show.
Thanks for having me, Kevin.
All right, let's start by briefly sharing your story, then we'll talk about your Kevin MD article.
Sure. So I'm a child and adolescent psychiatrist. I'm co-founder and chief medical officer of InStride Health, where we work with kids, teens, young adults who are diagnosed with anxiety and OCD. My story is after almost 2 decades in academic medicine, we built InStride to expand access to specialty pediatric anxiety and OCD treatment that actually works and is covered by insurance. This is something that we kind of saw firsthand in the trenches was a real problem for families and for clinicians. And so we're really hoping to kind of really contribute to tackling the pediatric mental health crisis. We chose anxiety because pediatric anxiety is the most common psychiatric diagnosis in kids and teens, and actually across the whole lifespan. And in its more moderate to severe forms, it can be absolutely debilitating. We've just seen over and over how it can completely derail a kid's development. It shrinks their world and it overwhelms the family system. And we've also seen how treatment can really help kids and families get back on track. They get their lives back. And it is just such an amazing feeling as a doctor to be able to do good in a kid and family's life. But the sad part is that not enough kids and families are getting that right help when they need it. And so instead, things just keep spiraling. And so by the time they get to treatment, they've accumulated disabilities and accumulated challenges. And it's just so much harder to treat them in their system. And so our hope is that we take this treatment that works and we really think about the whole biopsychosocial formulation and develop that treatment plan that really addresses all of the vulnerabilities in all of these categories. And so we at InStride really have a care team. It's a psychiatrist, a therapist, and a coach working together as a coordinated care team with the pediatrician, with the school, and with the family. And we're all really trying to understand what's driving the anxiety and using that whole toolbox to provide that surround sound. And so my article focused on within the biology, the medication component of what we hope is like a more comprehensive approach to really helping these kids and families.
All right, so before talking about the article, tell us some numbers in terms of the prevalence of anxiety in the pediatric population and maybe some root causes why those numbers are increasing.
There are lots of epidemiological studies. I think the most recent that we've been seeing is by age 18, about a third of kids will at some point have had a diagnosis of anxiety or OCD. And again, it ranges from anywhere in the mild to the more moderate to severe. What I've been seeing clinically is that anxiety, even before the pandemic, was already starting to escalate. And also, when kids were coming to us, they were coming in more disabled. The anxiety was just bigger and more severe. And I mean, there are all kinds of things that we talk about that can be contributing to this. Again, we think about biopsychosocial, there's the biological vulnerability. And then when you have the biological vulnerability and add to it environmental stressors and kind of attacks on the psychological system to manage those stressors, you can see how it just accumulates over time.
And typically, how would these teens and kids, how would they present to their pediatrician? Like, what would their most common story be?
So anxiety can present in a lot of different ways. So for especially the younger kids, oftentimes it presents more physically. And so they might actually notice is that the kids are actually going to the school nurse, complaining of a headache or a stomach ache or just a hard time, like kind of just physically staying in class. And other kids might present more behaviorally. And again, especially when they're younger, they might not have the words to say, I'm feeling anxious. So instead, it might come out with meltdowns or refusal to do things or just what seems like willfulness when it's really fear-based. And so again, we kind of really think about anxiety as a spectrum of how it presents, physical component, and then we talk about our stress system, fight, flight, freeze. You might have that typical avoidance of things that are stressful, looking for reassurance that everything's going to be okay. But you also might find kids who just get angry and irritable because that fear is just so overwhelming and consuming.
Now, in your article, you make that distinction between everyday worry and clinical anxiety. How can parents recognize whether anxiety has crossed that line?
I think it's important for all of us to understand anxiety happens on a spectrum. And In the mild end, it's a very normal part of being human, and it can actually be helpful and protective. So I don't want to overpathologize. Our goal is not to get rid of anxiety, but instead our goal is to say, let anxiety show up and let it motivate it, let it do its thing, and then let's move on from it. So again, in its mild form, it informs us that something matters. It can help us prepare for a test. It can help us avoid danger. It's part of how we survive and even sometimes thrive. But again, it comes, it motivates action, and then it resolves. And when it resolves, it gives our minds and our bodies a chance to recover from that
Mhm.
episode. But when clinical anxiety comes along, it is a very different beast. Clinical anxiety does not motivate, it paralyzes. It doesn't come and go, it persists. So it creates this filter through which the child experiences the world. It makes things scarier than they are. It tells the child that they have less agency and ability than they do. And so then it starts shaping their identity and it starts shrinking their world. So what I say to parents is that we all have feelings. Feelings are important. They communicate to us. And so what we want to make sure that we're doing is identifying these feelings and recognizing what action urge comes from these feelings. And when it's productive, and it doesn't always feel good, but
Mhm.
when it's productive, that's great. But when it starts becoming unproductive, when the anxiety starts calling the shots, when the anxiety starts causing a child to make a decision that is not consistent with what they're expected to do or what their values are, that's when it starts becoming something that we really want to make sure that we're identifying and getting help for.
As you said before, your Kevin MD article talks about one facet of that holistic approach to anxiety is titled When Anxiety Runs the Show, How Medication Can Help Kids Thrive. Now, tell us about your Kevin MD article for those who didn't get a chance to read it yet.
Let me start with a story.
Sure.
So, 13-year-old kid, smart, kind, talented soccer player comes into my clinic. And for the past couple of weeks, she's stopped going to school. She stopped going to soccer practice and games. She stopped hanging out with all but one of her friends. And so this is a kid who used to love learning, pushed herself to compete, begged for sleepovers. And now the thought of leaving her house and engaging the world completely sparks a panic and just derails her and the whole family. And her parents are so loving and they're so worried and they've tried everything. So they've tried therapy, they've tried breathing exercises, they've tried reward systems, even tough love, and nothing was working. And things are just spiraling very quickly. And so what often times happens is one of two things. One, parents are just very reluctant to start medication because it's a developing pediatric brain. It is really important that we are cautious about what we're giving to this
Hmm.
pediatric brain. And so it's very understandable to be reluctant and to be cautious about considering medications. Or what I might also see in my practice is a child comes in and they were started on medication, but we call it the demoralization titration, where they started on a low dose and they've been kind of staying on a low dose. And so the parents are coming in saying, and we've even tried medication and that's not helping, and we are at a complete loss. So why I wrote the article is to really encourage us to see medication as a real tool and to think about when we use it to really commit to using it as the tool that it is, because again, anxiety untreated is really devastating for a child. It really derails. And so when we treat, let's make sure that we're really being thoughtful and deliberate about using the tools that we have.
And when you talk about medication, tell us about your approach from the perspective of a pediatric psychiatrist. What classes of medication we're talking about, and what would give you the decision to start medication in a particular case?
Yeah, and so for me, it's when a child comes in and it's kind of we're trying to make the decision, do we start medication or not? The question is not, does this child have anxiety or not? The question is, how is the anxiety showing up for this child?
Hmm.
What have they tried? And again, it's looking at the biopsychosocial piece. And so at at InStride, we start with the therapy evaluation, and we actually really do try to have the child and the family engage in therapy first. And what we consider when we consider medication is when we notice that the child's anxiety has such a high volume that it is really difficult for that child to be able to even learn the therapeutic tools or engage in the exposure therapy,
Hmm.
the behavioral part of the therapy that has been shown in research to be the active ingredient. And so, again, I talk through the risk and benefit of medication, but also the risk and benefit of not medication. And so, what we're trying if it's not working, then we want to say, is this a time for us to think about medication as a possible tool? And I think about it as if we're addressing the biology, what we want to do is turn down the intensity
Hmm.
of anxiety with the medication. So the medication's role is not to get rid of the anxiety. It's to say, let's turn it down enough so that this child, instead of avoiding, because anxiety is just so overwhelming, this child is approaching life. This child is trying the skills. This child is giving themselves a chance to be uncomfortable and see that they can get through it, that they don't have to avoid things just because anxiety tells them they can't do it.
And what particular classes of medication are particularly suited for the pediatric population?
So the gold standard in our child psychiatry world for anxiety treatment is the class of SSRIs, selective serotonin and reuptake inhibitors. And so I reference frequently the CAM study. It's a landmark randomized control trial that had four arms. It had cognitive behavioral therapy. It had an SSRI. They used sertraline. It had CBT and medication together, and then placebo. And what they found is that the combined CBT plus SSRI outperformed all of the other arms. They also found that CBT alone and medication alone were about equally
Hmm.
efficacious, and they found that all three arms outperformed placebo. And so how we interpret this research is that for mild cases of anxiety, starting with just therapy, particularly CBT, cognitive behavioral therapy, is a very reasonable approach. As the anxiety starts getting more severe, as it starts interfering, that combination treatment can really help address the multiple factors that might be causing the anxiety. And again, SSRIs are usually the first line treatment for that. Within the SSRIs, there really is no major difference. Each medication might have slight differences. For example, fluoxetine has a longer half-life. And so in somebody where you're worried about compliance, you might consider that medication. Although if you're worried about a family history of bipolar disorder, you might not consider fluoxetine because it takes longer to get it out of the system. And so you might consider medications based on some of the factors, or if a family comes in saying, we've had two generations who have really benefited from this particular SSRI, we'd really like to try this. There is something to be said about treatment expectations. And so I will ask if they have an aversion to any specific
Hmm.
medication, or if they've found others who have benefited from it, and again, kind of work collaboratively. Because what we also find is compliance is one of the biggest barriers to effective medication management, that oftentimes when we prescribe it, patients will not take the medication as prescribed. And so
Hmm.
from the get-go, ensuring that we do the work to help them understand why they're on it, what the treatment targets are, what the side effects are, and have an open communication will hopefully improve that compliance. Because if they're not taking it, it's going to be very hard for it to be effective.
How do you talk to families about what to expect during a medication trial and how to gauge progress?
Yeah, and so again, I'm very clear about treatment expectations. We are not looking for this to all of a sudden make everything better.
Hmm.
That is not the goal. The goal is to turn down the volume of the anxiety so that we can now start feeling uncomfortable and being willing to sit in that discomfort. And so one is just being very clear about the expectations. Two is saying that these medications generally are quite well tolerated, and now they've been around for long enough and we've used them in children. There are some that are FDA approved, some that are not, but we have now used them for a long enough period of time that we have seen that they're generally a safe class of medications to use in kids. And that being said, we are always cautious when we're medicating kids. And so we want to make sure that we have open communication, and that if you notice anything, that you talk to me about it. Oftentimes what we notice is people with anxiety disorders are also very sensitive to side effects. And so I will often say, do you want me to run the whole list or how do you prefer we talk through the side
Hmm.
effects? Because what I also don't want to do is make them anxious by running an entire list. And so I'll usually kind of before starting a medication ask about frequent side effects. So I'll ask about headaches, I'll ask about stomach aches. So I have a baseline
Hmm.
so we can really decipher if headaches, stomach aches down the line are truly side effects or if they're just part of the anxiety disorder picture.
Now, in those cases where the medication is successful as part of that holistic strategy, how do you determine how long they stay on medication for?
Particularly because these are kids and adolescents, their brains are so malleable. They're growing, then developing. And again, if they're engaging in therapy, they're shifting the way they're responding to anxiety and they're really retraining their brain. And so this is what I talk about with families. We are really wanting to give them a chance to grow up and experience the world as they are, not filtered through anxiety. And so it's very reasonable, especially with a first trial of medication, to expect that this is not a long-term sentence, and we really should try a taper once things are stabilized. We borrow from adult literature on this one, and what we generally talk about is after 6 to 12 months of stability, sometimes 18 months, depending on how severe it was, we want to start discussing a slow and thoughtful taper. And stability meaning they're going to school, they're functioning, they're still feeling feelings, but when that anxiety comes up, they know what it is, they know how to manage it, and it is not dictating their behaviors or dictating their decisions. And so after that point of stability, I'll say, let's try a slow taper. And I say taper because worst case scenario, you find a lower dose that is just as effective at managing that anxiety. And best case scenario, you slowly taper and you're able to take the child off of the medication. And now they're really engaging in the world with the new skills that they've learned. When we treat, we really aim for remission, not just response. I think it's a very important distinction, and this is what our research shows us too. When you aim for remission, that is when you have a better chance of long-term change.
We're talking to Mona Potter, psychiatrist and physician executive. Today's Kevin MD article is When Anxiety Runs the Show, How Medication Can Help Kids Thrive. Mona, let's end with some take-home messages that you want to leave with the Kevin MD audience.
Take home is that pediatric anxiety is very common. It can get very debilitating, not just for the child, but also for the family. And it is also treatable, but through a biopsychosocial model that involves the entire system that surrounds the child.
Mona, thank you so much for sharing your perspective and insight. Thanks again for coming on the show.
Thank you for having me.